have the pleasure of co-chairing this session with Dr. D.W. Park from South Korea. And this session is entitled All About New Data of Antithrombotics. We have two sessions within this main session, one on antiplatelets and one on anticoagulants. We have a number of distinguished panelists, Dr. Bangalore, Dr. Cohen, Dr. Kim, Dr. Palmerini, Dr. K.W. Park, Dr. Smits, and Dr. Yokoi. We will have time also for discussion, and we look forward to some very, very entertaining lectures. We'll start off with the first presentation entitled Standardizing the Language on Bleeding and Ischemic Risks, Insights on ARC, BARC, VARC, and others by Dr. Pieter Smits.
Thank you, Dominick, for the introduction, and it's a pleasure to talk to you about this topic. This is my disclosure slide. So the Academic Research Consortium is an international collaborative forum across medical device stakeholders that includes academics, clinical trialists, regulatory bodies, and industries. It was founded in 2006 by the next representatives, the BAME Institute for Clinical Research in Boston, the Cardialysis Union and ACRI in Rotterdam, the Netherlands, the Cardiovascular Research Foundation, New York, USA, and Duke Clinical Research Institute, also in the USA, as well as CIRC in France, Massy, and the United States Food and Drug Administration. The purpose of the ARC is to create a dynamic and transparent and a collaborative forum for stakeholders to develop consensus definitions and standard nomenclature in pivotal clinical trials of medical devices and also drugs, and to disseminate such definitions and recommend processes into the public domain. And why is it so important that we speak the universal, that we speak all the same language? Because it makes it possible to compare between devices, drugs, strategies, and trials, and facilitates the clinicians in better understanding research outcomes and to help them in their clinical decision making. It also facilitates the regulatory of notified bodies to understand which drugs or devices are safe and should be adopted into the market. And it facilitates industry stakeholders to develop their regulatory studies and support investigator-initiated studies. And in the end, the patients will benefit because in the end, they will get the best drug and the best dose and the best device. And also there will be an early adoption of innovative drugs and devices to them. Why it's so important to speak the same universal language is, for instance, in this bleeding study, in which in the same ACS populations, two bleeding definitions were evaluated, and we have many bleeding definitions. We have TIMI, Gusto, Grace, Cure, Acuity, Horizons, ISA3, and so on. And if we only compare, for instance, the TIMI, the original TIMI classification, and we compare that with the Gusto classification in the same population, we see that there can be a huge difference in outcome on hazard ratio for MI and death at the first 30 days. It could be a fold difference if one uses the one or the other criteria for major bleed. And the same applies as well for ischemic events, for instance, like the periprocedural MI. It really makes a huge difference if one assesses biomarkers based on CKMB or on troponin alone. And you can see that here on the left, in one study, that can be only 1.8 periprocedural MI with CKMB, whereas when you use the criteria of troponin, it can be more than almost 8 times more. And if one look across the other definitions, like the first universal definition of MI or ARC2 or the syntax or Excel, etc., you can see that there is no much conformity. And on the right hand, you can see that actually troponin alone has, on the SKY definition, has not so much a high predictive value on death if you compare that, for instance, when you have no MI. So the ARC group has so far published 16 consensus papers on, for instance, on coronary artery disease. You know well, you very well know, familiar with the ARC2 paper. Bleeding events, the BARC, the neurological events, the aortic valve disease, the VARC, then the mitral valve disease, the peripheral artery disease, the PARC, the high bleeding risk, the ARC-HBR consensus paper, and the bifurcation BIF ARC, as well as the consensus paper on CTO, the CTO ARC, paravalvular leaks, hypertension and heart failure and mechanical circulatory support, medical therapies, the NARC paper, and tricuspid valve and cardiogenic shock, one of the latest. So why is it so important we speak the same language? If you look at the bleeding classification, it should at least it should address many things. It should address the cause, whether it is procedural or spontaneous. It should address whether it is the site, whether it is access or non-access, or whether it is compressible or not compressible. The severity, should it have impact on life or on functional status, and should it impact treatment. It also should correlate with prognosis. It should also be easy to use, and it should guide treatment. And for that, I think one of the most used consensus paper now is I think the bleeding consensus paper on the BARC, next to the ARC on stent thrombosis, and this is nicely represented now that we have those 5 criteria on bleedings. As well, we have a nice paper on high bleeding risk, where you have the consensus group identified 10 factors that were associated with high bleeding risk, like age, renal disease, liver disease, active cancer, anemia, thrombocytopenia, neurological stroke, and ischemic hemorrhage, and arterial venous malformations, bleeding diathesis, prior bleeding and transfusion, oral use or chronic use of non-steroid anti-inflammatory drugs and steroids, or planned surgery. And with a large database that was provided by all the clinical trialists and industry, they identified 10 major HBI criteria or 6 minor high HBI criteria. And how did they came up with those criteria? Because they analyzed the data, and that was by Stuart Pocock, and they identified that major criteria was if the risk for a BARC 3 or 5 bleeding was 4% or more, or if there was a risk on an ischemic cranial hemorrhage, an intracranial hemorrhage was 1% or more within the first 12 months post-PCI. The minor criteria was when there was a risk BARC bleeding of 3 and 5, less than 4%, or a risk of an intracranial hemorrhage was less than 1% within the first 12 months after PCI. So the ARC-HBI for high bleeding risk patient, if there was at least 1 major criteria or 2 major criteria. Are we speaking the same language for ischemic risk? I'm not so sure. I think we still have some work to do. If we look at 2 recent published papers on comparative stent trials, the Onyx-1 and the Bioflow depth, and you look at more or less the same population, minor differences, but they all get 1 month's DPT. You can see that in the Onyx-1, using the third universal definition of MI, the TLF rate is around 13%, whereas if you have the Bioflow depth study and you look at the same endpoint, TLF, but you have the MI according to the ARC2, you have a 4-fold lower TLF rate. So I think there is still some work to do in this respect. And so in conclusion, ladies and gentlemen, the ARC initiative has created a unique platform for standardization of trial endpoints. It will facilitate research and regulatory work, making outcomes and comparisons of devices and medical strategies better interpretable, and consensus on bleeding endpoints and identifying patients at high bleeding risk. So ischemic endpoints, and specifically the periprocedural MI, I think remains to be better defined or represented. Representing meaning one should represent all the ischemic periprocedural MI risk based on all the different criteria. Thank you for your attention.
Thank you, Pieter, for the excellent presentation. We'll move on to the second presentation, which will be by Dr. Tullio Palmerini, who will be speaking about escalation strategy of antithrombotic therapy, why, in whom, and how.
Thank you. These are my disclosure. So escalation antiplatelet therapy is increasing in intensity of platelet inhibition by switching to a more potent antiplatelet drug by increasing the dose or adding on a standard antiplatelet therapy. Why? The rationale of escalation antiplatelet therapy is to reduce the risk of ischemic events without paying a price in terms of bleeding. In which patient? This is, to me, the most important question, because when we talk about escalation antiplatelet therapy, the benchmark is clopidogrel. Now, if we have a trial in which we want to implement escalation antiplatelet therapy and we include patients with acute coronary syndromes. Now, we are comparing escalation therapy versus a suboptimal therapy in patients with acute coronary syndrome, which is not clopidogrel, but prasugrel or ticagrelor, in order to reduce the risk of ischemic events. So the patient would be a patient with stable coronary artery disease or a specific patient with acute coronary syndromes. How we can do escalation therapy, guided or unguided by platelet function testing or genetic testing. So switching to a more potent antiplatelet drug, this can be applied to patient on dual antiplatelet therapy or patient on single antiplatelet therapy, but we have data on patient on dual antiplatelet therapy. The literal definition of escalation antiplatelet therapy would imply a period of dual antiplatelet therapy with clopidogrel plus aspirin, followed by a more intensive regimen. So we start with ASA plus clopidogrel, then at some point we give ASA plus prasugrel or ticagrelor. But why should we do that? So this is just a theoretical possibility, no clinical data, no clinical rationale for that. So a broader definition would imply intensification of dual antiplatelet therapy up front compared to what would be the default strategy. So we should give, according to guidelines, ASA plus clopidogrel to a patient. Now we decide to give ASA and upscale to prasugrel or ticagrelor. And the clinical context would be that of patient with stable coronary artery disease, a high thrombotic risk, and low bleeding risk. So we have two trials on unguided escalation antiplatelet therapy, Alpheus, almost 2,000 patients, ticagrelor versus clopidogrel, Sassicaia, almost 1,000 patients, prasugrel 60 mg loading dose versus clopidogrel 600 mg loading dose. Both trials were negative. So at the moment there is no proof that escalation antiplatelet therapy based on unguided escalation antiplatelet therapy is of any benefit. So escalation can be also achieved by platelet function testing and genetic testing. So we have two old trials with the platelet function testing, ARCTIC and TRIGGER-PCI. They were both negative. Why is that? So there is no doubt that high on-treatment resistance to clopidogrel, poor responsiveness to clopidogrel is a risk factor for stent thrombosis and myocardial infarction. These are the data of ADAPT-DES, but now look at patients with no stent thrombosis. There is a large number of patients with high on-treatment platelet resistance that had no events. Or stated in other terms, the positive predictive value of platelet function testing is very low, 1.2% for stent thrombosis, 3.8% for myocardial infarction. In a situation like that, when you have a test with a low positive predictive value, you need a large number of patients to find a significant difference. We have a more recent trial, which is a CHIP-PCI trial, which used a novel assay, which is called PL12, and it measures maximal aggregation rate, which is if this parameter is more than 55%, the patient is defined to be resistant. And indeed, using this device, the personalized group had lower rates as compared to the standard group. But there are many caveats to these studies. There is an ethic issue because this is a Chinese study, and we know that Asian population may have a different way to respond to antiplatelet therapy. It's a single-center study. The device was never validated in a population other than the Chinese population, and the endpoint was mainly driven by urgent revascularization, and this may raise some concern because this is an unblinded study. Genetic testing, how we decide whether this is an escalation, de-escalation trial, we have to look at the control arm. So if the control arm is ASA plus clopidogrel, de-escalation in CHIP-PCI loss of function allele patients would be treated in the experimental arm with ASA plus prasugrel or ticagrelor. We have 3 trials. And the largest one is the CHIP-PCI trial. More than 5,000 patients randomized, but finally only patients with loss of function allele were analyzed for the outcome. So we have 903 patients who were carrier of CHIP-PCI loss of function allele treated with ticagrelor, and 946 treated with clopidogrel. Again, there was no significant difference between conventional therapy and genotype-guided therapy. And if you look also at the event rates in the control arm, so these are CHIP-PCI loss of function allele patients treated with clopidogrel, event rates of ischemic events was very low, 1.5% myocardial infarction, 0.9% stent thrombosis, and cardiovascular death. So very difficult with such low rates of events to find a significant difference. So all these studies have been collected in this meta-analysis, which indeed suggest that some ischemic events may be reduced with guided escalation strategy. But this meta-analysis should be interpreted with caution because heterogeneity was very high, 82% for major adverse cardiovascular event, 66% for myocardial infarction. And when you have such a level of heterogeneity, it is difficult to generalize the results of a meta-analysis. So this is the reason why escalation antiplatelet therapy for patients with stable coronary artery disease is class 2B, level of recommendation C in the European guidelines for patients with stable coronary artery disease at high thrombotic risk. Escalation by dose increase. We can increase clopidogrel loading dose from 300 milligram to 600 milligram. We have the Albion study, but this is a pharmacodynamic study, no clinical events. We can increase the maintenance dose from 75 to 150. Current OASI 7, gravitas, a significant reduction in ischemic events in current OASI 7, but not in gravitas. And we can increase the dose of aspirin from 75 to 300. We have 2 trials. Current OASI 7, adaptable, again, no significant difference between the 2 strategies. Finally, add on single antiplatelet therapy, adding clopidogrel, we have the DAP trial, adding ticagrelor, we have 2 trials, Pegasus and Themis, adding rivaroxaban, we have the Compass trial. All these trials have shown a reduction in ischemic events, but an increase in bleeding events. So, in conclusion, despite the need of a tailored approach for balancing ischemic and bleeding risk and the strong rationale for escalation antiplatelet therapy in specific clinical contexts, more data are needed for a broader implementation of this strategy. Thank you.
Thank you, Tullio, for the nice presentation. We'll now go on to the other side of the equation, which is de-escalation. And Dr. Bangalore will be also explaining why and whom and how.
Thank you very much. I think that was a great talk in terms of escalation therapy. So let's talk about de-escalation. So I have no specific disclosure for this particular talk. So in terms of antiplatelet consideration, as we all know, we are trying to do a fine balance between bleeding and ischemic risk. And we know from a number of data that both of these ischemic and bleeding events are very important because they are closely tied to the increased risk of mortality. So in terms of DAP consideration, in order to, if you purely look at P2Y12 potency, In order to prevent ischemic events, we should be using a more potent P2Y12 agents, typically prasugrel, ticagrelor. And to reduce bleeding event, we should be using less potent P2Y12, which is either clopidogrel or reduced dose P2Y12. In terms of duration for DAPT consideration, to reduce ischemic events, potentially longer DAPT, and to reduce bleeding event, potentially shorter DAPT, either by continuing aspirin alone or by continuing P2Y12 alone. And I think it's important, this slide is important in terms of timelines of ischemic versus bleeding risk after acute coronary syndrome. And this kind of emphasizes why starting a therapy and continuing it for a long duration of time may not be ideal, because the risk of ischemic events is significantly higher within the first 30 days. And you can see here the bleeding risk, although around the time of the procedure is higher, it tends to be steady over a period of time. And the ischemic risk reduces with time, and it's potentially lower compared to bleeding risk after a certain period of time. Even with this equation, there is a higher risk of ischemic events in patients who present with ACS, complex PCI. And patients who have, there is also increase in bleeding risk in patients who are deemed high risk of bleeding, patients who are on oral anticoagulants, and those with potent P2Y12. So if we look at this kind of background, so it does make sense to say to use a more potent P2Y12 around the time frame where there is increased risk of ischemic events, and then follow a de-escalation strategy where you can go back to lesser potency P2Y12 or shortened duration to reduce the risk of bleeding. So let's talk about de-escalation strategy, and this is based on ARC definition. So how can we de-escalate? So you're starting with the potent agent. You can de-escalate by either switching from a potent P2Y12 to less potent P2Y12. In this case, it will be clopidogrel. You can also do a dose reduction, which would be if you start with ticagrelor or prasugrel, use a lower dose ticagrelor or prasugrel. And the third way of this de-escalation is to reduce the duration of DAPT therapy by dropping either aspirin or P2Y12. Let's talk about each of these strategies in terms of de-escalation. First, let's start with de-escalation strategy by switching or by dose reduction. And if you look at some of the data, so this is a meta-analysis looking at de-escalation from potent P2Y12. So you're starting with patients with ACS, aspirin and potent P2Y12. And you, this analysis compared patients with standard DAPT to a de-escalation strategy, which was either genetically guided or platelet function studies guided or unguided de-escalation. And as can be seen from the summary of these 5 randomized trials, there was significant reduction in bleeding with the de-escalation strategy, and there was also a significant reduction in cardiovascular events by using this de-escalation strategy. I want to focus on specific trials here so we can kind of get an insight about de-escalation strategy and apply it in your clinical practice. What I've done specifically in all of these trials is to focus on patient subsets which have the highest thrombotic risk, which are patients with STEMI. And I think that's why it's important for all of these trials to understand what proportion of patients with STEMI were included in these trials. In the Talos AMI trial, this was a de-escalation at 30 days, which was unguided, no loading clopidogrel strategy. 2,600 patients, half of them were STEMI. Patients were randomized to aspirin plus ticagrelor for 11 months, or de-escalated to aspirin plus clopidogrel for 11 months after a mandatory 1 month of aspirin and ticagrelor. And here, de-escalation resulted in a significant reduction in NACE, driven by significant reduction in bleeding, and you had no penalty to pay in terms of increase in ischemic risk. This is one strategy which has been shown to be beneficial. You're not paying a price in terms of increase in ischemic risk. The other trial, which looks at de-escalation at 30 days, is the TOPIC trial. Again, a good representation, 40% of patients with STEMI, this time comparing de-escalation to clopidogrel, but this was a fixed dose combination. The standard group received either ticagrelor or prasugrel, and the results were very similar. De-escalation reduced NACE, driven by reduction in bleeding, no difference in ischemic endpoints. What other strategies can we do in terms of de-escalation? One is by discontinuation, so making the comparing shorter DAPT with the standard potent DAPT. So we can either shorten the duration of DAPT at around 3-month period of time. This was studied in the Twilight ACS trial. Important to note that Twilight excluded patients with STEMI, so this was an N-STEMI ACS cohort. So at 3 months, aspirin was dropped. So this was continuation of ticagrelor versus aspirin plus ticagrelor. So 3 months DAPT compared to 12-month DAPT reduced bleeding, and there was no difference in MI and no difference in stent thrombosis. The STOP DAPT2 ACS trial had around 56% of patients with STEMI. After 1 month, there was in the short DAPT arm, aspirin was dropped, so there was continuation of clopidogrel compared to 12 months of DAPT. And I think this trial is important because the 1-month DAPT when compared to 12-month DAPT was not non-inferior, so it failed to meet the primary endpoint. There was in fact an increase in MI risk, and this is one of the reasons why in STEMI patients, dropping aspirin and just doing clopidogrel after a month is potentially should not be done based on this trial. I also want to mention the TPAS trial, which was testing a strategy of less than 1 month of DAPT versus 12 months of DAPT, and 40% of these patients had STEMI. Here, aspirin was dropped, but the P2Y12 used was ticagrelor, and the comparison was aspirin plus ticagrelor. And less than 1 month DAPT significantly reduced NACE, driven by reduced bleeding. There was no difference in ischemic endpoints, suggesting that if you have to drop aspirin early, you better be on a more potent P2Y12 agent. And more recently, the ultimate DAPT tested 1 month versus 12 months. Again, ultimate DAPT, in the 1 month DAPT, it was ticagrelor, which was continued. 28% STEMI patients, again, significant benefit, reduced NACE by reducing bleeding. And the STOP DAPT3 trial tested 0 months of DAPT, where upfront patients had prasugrel 3.75 milligrams compared to 12 months DAPT of aspirin plus prasugrel. Nearly half of the patient had STEMI. There was a significant increase in subacute stent thrombosis in this trial. It may be related to the prasugrel dose of 3.75 milligrams, so some strategy not to follow this. So in the interest of time, let me skip this, and we have a number of meta-analyses, including what we have published here. But just to summarize in terms of practical approach, I mean, this is a slide I modified from Dominick's presentation. In patients with ACS, the strategy that I like is start with a potent P2Y12 agent, so aspirin and potent P2Y12. I think we have data as of today that at 1 month you can follow a strategy of de-escalation. So at 1 month you can either do a strategy where you mitigate P2Y12 inhibition. It could be either an unguided switch to clopidogrel or a reduced dose P2Y12, or it could be a guided strategy. The other strategy to follow is a single pill strategy of shortening DAPT, and the best evidence we have is by dropping aspirin and doing a ticagrelor monotherapy in these group of patients. So the things to be avoided are to do a clopidogrel monotherapy in ACS patients after 1 month. Let me stop here. Thank you for your attention.
Thank you for the comprehensive presentation, and we'll move on to the last presentation of this session, which will look at both escalation and de-escalation strategy for CHIP-PCI patients, the tailored CHIP trial, which will be presented by Dr. Park.
Thank you, Dominick. And this trial is combining the two topics, escalation and de-escalation, in the tailored CHIP trial. This is my disclosure. So, and the key randomized trial is over the last 10 years is performed in the Asian Pacific region, and we 15 years ago published in New England Journal of Medicine, just and the relay trial. Until recently, a lot of clinical trial regarding intensity or duration is published recently, and the Talos AMI Lancet 2021, and the TPAS trial in circulation last year, TCT late-breaking trial. So, and as you mentioned in the two presentations, novel contemporary trend is the dynamic changes, pragmatic antithrombotic strategy after high-risk PCI escalation and de-escalation. This is a very nice paper and done, and the David and the Dominick, and this is ARC white paper is published in Circulation. It's a well-written paper. It's targeting the reducing ischemic risk de-escalation and increasing the escalation about the platelet inhibition. This slide is already shown in the prior presenter. And the modulation we can do, and the de-escalation or escalation, and the de-escalation is you can reduce the switching less potent drug or dose reduction or discontinuation like aspirin. And the escalation is a switching drug and the dose increase or the add-on the method, and we have a very dynamic and the diverse combination of the drug. And as shown is the Bangalore, and it's about the temporal antithrombotic. The tuning is of a very nice review article done. It's Robert Harrington in the Stanford. It's published 2021 New England Journal of Medicine. This is focused on temporal, the risk of bleeding and thrombotic is different in ACS patient. As shown, the Sripal. This is the same for the complex patients in left main in the bifurcation region. So that would be rational in the early part. We can do some escalation, and the later part we can do de-escalation. So, and I'm gonna mainly focus on the tailored CHIP trial. This is started nearly 4 years ago before COVID-19 period, and we have completed all the trial enrollment, and is 2,000 patients is underwent the complex high-risk PCI. We call the CHIP population, and the definition is a left main and CTO bifurcation requiring 2 stent and the severe calcified region, and the trial scheme is a conventional arm, is clopidogrel plus aspirin, and the versus tailored arm early part 6 months, we use the ticagrelor 60 milligram plus aspirin, the early escalation, late part clopidogrel alone, late de-escalation. So this is the trial rationale after CHIP procedure, and the early part would be require more potent strategy early for early ischemic risk, and we select ticagrelor 60 milligram plus aspirin later part to reduce the bleeding event, less potent for late bleeding risk, clopidogrel only aspirin-free strategy. So the audience think about why use the low dose 60 milligram ticagrelor. This is based on our PK/PD trial published in JACC 2018. We did optimal trial for targeting SCS population. We are blinded randomization, ticagrelor 60 milligram, 90 milligram, looking at PK pharmacodynamics, and the pharmacodynamics, the platelet inhibition effect, the 60 milligram quite comparable is compared to the ticagrelor 90 milligram, is a very better platelet inhibition compared to clopidogrel. That is the reason why we select ticagrelor low dose 60 milligram. This is also confirmed the THEMIS and the Pegasus trial, and the showing 60 milligram shows a much beneficial trade-off ischemic and bleeding risk. So our trial inclusion criteria, we use the contemporary second generation, third generation drug-eluting stent. We confine the very high risk anatomical factor, left main disease, bifurcation region requiring 2 stents, CTO, severe calcified region, diffuse long region more than 30 milligram, multivessel fisheye, and at least 3 requiring stent implantation. At least 3 regions will be treated or predicted total stent length more than 60. And in clinical factor, diabetic, CKD, or severe LV dysfunction. And exclusion criteria, and we excluded enzyme positive ACS non-STEMI or STEMI. This population absolutely requiring the standard dose ticagrelor, the main reason we exclude them. Also, we exclude the need for chronic oral anticoagulation like warfarin or DOAC, and the AP population is extremely excluded. And the trial and active bleeding or extreme risk for major bleeding was also excluded. In the primary endpoint, we combining net clinical benefit, all-cause mortality, MI, stroke, stent thrombosis, urgent revascularization, clinically relevant bleeding BARC 2, 3, or 5, and also we evaluated the diverse ischemic and bleeding. The outcome is our targeting concept is temporal dynamic treatment benefit after CHIP procedure. Early part, we targeting is early escalation, reduced ischemic risk, and the later part, we targeting lowering the late bleeding risk. That was our rationale of the tailored CHIP trial. We completed 2,000 patients, is 100% enrolled. We are planned to final result will be planned to be presented the next year ESC meeting in Madrid in Spain. So my final key message, optimal antithrombotic strategy is cornerstone of management ACS or PCI, is consistently evolving to balance ischemia and bleeding risk, and modulation, antiplatelet therapy like escalation, de-escalation is evolved over the time. Optimal intensive plate inhibition is varying according to stage, clinical presentation, and individual patient factor. And also escalation, de-escalation can be done different way by changing the drug type or dose and the number of antiplatelet drug. And still for targeting CHIP population is a limited data. Our tailored CHIP trial provide important clinical insight and temporal antiplatelet modulation with early escalation and rate de-escalation in high-risk CHIP population. Thank you for your attention.
Thank you very much for that wonderful presentation, and Dr. Cohen will join us. So we now have around 15 minutes for questions. If anybody from the audience has any questions, please come to the microphone and introduce yourself. I have a first question for my co-chair, Dr. Park. So congratulations on the trial. So your tailored arm is tailored by definition because you're modulating the intensity of antiplatelet therapy. But within that arm, are you collecting genetic data, platelet function data?
Yes, so, and it's frankly speaking, we are unguided, it's a modulation. In our routine practice, we don't frequently use the genotyping and the platelet function test anymore, and it's some different in your country and some center. And we now is many center in South Korea doing just unguided modulation. In tailored CHIP trial, just to do unguided modulation.
Thank you. So one question at a time,
Okay.
please.
I have a question to the Dr. Bangalore and Dr. Palmerini. So regarding the antiplatelet therapy, so always problem and always key, always has the by risk group is old age and CKD and anemia patient. However, so there is no specific is kind of a guided or some tailored treatment for this subset. So, for example, the de-escalation strategy, the old age has the even with some kind of ischemic event. However, bleeding event is more severe. That is the key, and also the data based on the this high risk group. However, the escalation therapy is sometimes ischemic event is more frequent in old age group. So this is very kind of confusing. So the what do you think the management of this by risk group?
Yeah, if I can start, I mean, I think, you kind of highlighted the problem. I mean, we kind of have so many different trials, so many different combination. At the end of it, then we have patient subset which won't fit into any of these trials. I mean, we frequently face with patients who have CKD, who are elderly. And I think in all of these, where it's more of individualizing the individual risk of ischemic and bleeding events. In our practice, at least for all of the patients, there is a mandate that we calculate a bleeding risk for all of these patients. We do tailor it based on that. I mean, more in terms of duration of antiplatelet, also adding a PPI in this, trying to reduce the risk.
So I agree, you raised a very important point. but we do not have data. But for sure, I think also for escalation therapy, we should isolate those patients who may benefit the most for escalating therapy and study this kind of patients rather than being an overall strategy.
I asked you, Dr. Bangalore and Dr. Park, the de-escalation strategy. I think now Dr. Park trial that ticagrelor 60 milligram and follow up the clopidogrel 75, but the real world patient that, for example, that more than 75 years old, that's a bleeding high risk, body weight less than 50 kilogram. High risk, and the CKD EGFR less than 30. I think the more modify individual de-escalation more important. Lower beyond the 1 month that the patient is stable, beyond the 1 year more stable. So such kind of the patient that the individual de-escalation more important to clinical setting. How do you think that?
Yeah, so I think our trial is targeting mainly some CHIP population is mainly anatomically high risk. We cannot provide many comparison group and just mainly focus on our tailored group and the standard group, as you mentioned, the real practice and is a very fragile patient and the low body weight. We can sometimes do in the real practice. The trial is trial. We just do randomization our trial protocol.
Yeah, I have a comment on Dr. Yokoi's question. So I think the first thing we have to think about when we make these decisions is when we're actually seeing patients, the decision process is not something that you do pre-procedurally and then you have to stick to that strategy forever. So it's a dynamic process. You will reassess the patient every time you see the patient. So first thing is it's a dynamic process is the first thing. Second thing I think is important is in terms of the patients who have, in my opinion, recurrent ACS or STEMI, recurrent STEMI, or patient who has stent thrombosis, I put them in my highest tier of thrombotic risk. Other than that, at the beginning of the procedure, maybe some CHIP criteria, it's not as high as the previous, recurrent STEMI and stent thrombosis. Having said that, the first thing you look at is the bleeding risk. So if it's a patient that's like 80 years old, less than 50 kilograms, definitely high bleeding risk. And the first default strategy would be, even though that person may have had the first ACS event, if it's not recurrent, I would consider de-escalation at somewhere between 1 to 3 months. In my opinion, of all of the data, it has many different data, but it tells us one consistent story is you can de-escalate, you should not de-escalate to clopidogrel monotherapy, especially in East Asians who have a high proportion of CYP2C19 loss of function allele, to a monotherapy within a very early period. Other than that, I don't think we have enough data to really say what is the best therapy, because there is no comparison between ticagrelor. So in the Western population, maybe monotherapy to TICA would be the best, but there is no comparison of TICA in East Asian patient. So TICA versus prasugrel, there's no comparison. There's no comparison between TICA mono versus using clopidogrel in a depth fashion. So all of these areas is where the data is missing. But and that's where I think you have to use a personal judgment and personal experience.
Yeah, I have a question for Dr. Park. I know if we see all this data, we go more and more into a kind of tailored therapy. We have identified the high bleeding risk patients, and now we have specifically looking at those CHIP patients. But what is actually missing is, for me, is the universal definition of CHIP. I see your definition, and it's really a little bit different than I see from other CHIP definitions. And if we are going into a more and more tailored strategies for our depth strategies, I would expect that we also come up with a universal CHIP definition. Because what we are now using is what is a gut feeling.
So can I expand on this question, on this issue? So to me, the CHIP definition should be focused only on the complexity of coronary artery disease, because this is the sensible variable that can be modulated by antiplatelet therapy. But I saw that you also included something like left ventricular ejection dysfunction and things like that, which are not going to impact on antiplatelet therapy. Aren't you afraid that this is going to dilute the possible effect of the therapy?
Yeah, I think there is a very good point. You know, CHIP definition is still the lacking in our trial at the time of inception. We are mainly reference on the Ajay Katani white paper published in Circulation, also very good review article published in Lancet Journal. There was our trial mainly focused on anatomical complexity. We guess just diabetic and low ejection fraction CKD is also some sort of a clinical factor associated, increase the ischemic risk also could be associated with the bleeding risk, and we are combining. So in CHIP trial, most trial, more than 80% is met the anatomical complexity, less than 20% is met clinical complexity.
I have one comment and suggestion for Dr. Park. So I think the definition of CHIP in terms of left main, more than 3 stents, 60 millimeters, that was the first very arbitrary criteria that was used when Dr. Guistino did his JACC paper in the 7 randomized trial RCT. And that's when everybody started to use that same definition over and over for CHIP, but it's never been validated whether a left main intervention versus a 2-stent strategy has the same ischemic risk in the future. So definitely agree with you that we need to standardize the definition. I think what I would be more interested in the CHIP population is there is so much discussion about if you have a CHIP procedure, you have to prolong dual antiplatelet therapy. What I would love to see is to have your population and randomize at 1 year between clopidogrel monotherapy, which has been shown to be superior to aspirin monotherapy in the host exam trial, that one arm, versus continuing aspirin plus clopidogrel for another 2 years or whatever years, and just answer the question on whether we need to prolong DAPT in these CHIP patients.
So I have one question, Dominic, and so when I'm making the protocol paper for CHIP trial in the U.S. and the inpatient sample data is published last year, American Heart Journal, in the off-label use of ticagrelor or prasugrel in CHIP population, 30%. Is you right in real practice?
Yes, so there is a pretty high use of the potent P2Y12 inhibitors, even in the stable patients with complex coronary disease. I don't know if the number is exactly 30%, but it's pretty high.
Yeah, I think we use a lot of off-label potent P2Y12. But my question both for Dr. Park and Dominick is, this is a great trial. I mean, we need some data in the tailored CHIP population, and it's testing ticagrelor 60. I mean, we don't use 60 upfront in the U.S. So Dominick, to you, what would be the implication of this trial, regardless of the finding? What are we going to do with
Well,
this?
actually, I like it. There is some data amongst Westerners with the 60 milligram immediately after PCI. We've done it one in our group. It's the Optimus 6 study, and then from the UK, there's the Steel study. So I actually really like the dose because there's less side effects. In terms of what are the implications? As DW is saying, we do use a lot of potent agents. I think the 60 milligram has its advantages, but again, we'll see the results of the trial.
Will be available
Dominic.
next year.
Dominic, do you think we need a trial in stable patient with coronary artery disease comparing potent agent, probably de-escalating, versus standard treatment with clopidogrel and aspirin?
I think so because, for example, if you look at the Alphaeus trial, there are a lot of limitations there. I would love to see a trial which would be limited within the first few weeks, and then de-escalating.
Can I ask one over here? Sorry, I was late to the session, but one of the challenges we have, all of us is, you know, the number of different trials that have done a bunch of different things, and the challenges in reconciling all that. And I'm trying to figure out now, after all the trials and some of the talks that I've put together, I mean, have we ever beaten ticagrelor monotherapy after like the Twilight regimen, ticagrelor monotherapy after 3 months? I mean, I don't think, I mean, shouldn't that be almost the default at this point if we're really trying to use the evidence? It's not like we don't have small numbers of patients with that regimen. It's not like it's ever been beaten by anything, as far as I can tell. And you know, and I worry. I personally worry that the idea of it, I mean, individualizing made sense, but now it's taken on. It's so complex. The idea of individualizing. I think we risk making more mistakes than good by trying too hard to individualize, and just let's go with something that works darn consistently almost all the time.
We need to speak with the guideline committee.
I understand that. Well, but the FDA just approved it, right? They just, I mean, today, I mean, when I got my email from Roxana last night. I mean, I agree we need to, speak to the guideline folks. You're probably one of them.
Thank you. I think this session much hard, and so we're gonna move to the second session. It's about the anticoagulation issue. I'm very happy to introduce the absolutely global leader of antithrombotic strategy is Dominick, my friend, and don't forget about dual pathway inhibition and when DOAC should not be standard treatment.
Well, thank you for the introduction. So I will speak about dual pathway inhibition, and I will speak about when not should be standard treatment, but also when it should be considered in clinical practice. These are my disclosures. So let's start off with some basic concepts of atherothrombosis. We know that when we have a rupture of an atherosclerotic plaque, we have activation of two key pathways. We have the cellular pathway represented by platelets, and then we have the plasma component represented by thrombin. And there's an interplay between the two where the surface of the activated platelet is the main source for the generation of thrombin, and thrombin is the most potent inducer of platelet activation. And we typically block platelets when we send the patient home. We only use anticoagulants in the hospital. But we know that thrombin remains elevated even after hospital discharge. And this is what leads to the concept of dual pathway inhibition. In other words, blocking two different pathways leading to thrombosis, one on the platelets and the other one represented by coagulation. And there's synergism between these two pathways. Now, the concept of adding an anticoagulant to an antiplatelet in ACS it's an old concept. We knew about this with the use of vitamin K antagonists. With the introduction of the NOACs, these had been extensively tested, and for the most part, these trials actually failed, with the exception of one trial, which was the Atlas ACS, using the vascular dose of rivaroxaban, but this was on top of clopidogrel, so as a strategy, it was really never implemented. So what happened was one said, we're not going to use this in ACS. Why don't we look at this more for long-term secondary prevention? And this was on the background that we know that aspirin monotherapy is the standard of care for most patients with stable CAD and PAD. We know that ischemic events continue to persist even while on aspirin monotherapy. And there was some disappointment with the strategies of using alternative antiplatelet therapies. And so the question is, can a very low dose of rivaroxaban, 2.5 milligram BID, which is known as the vascular protection dose, in addition to aspirin or DPI, reduce ischemic events? Now, this was tested in the COMPASS trial, a very, very large trial with almost 30,000 patients. And as you can see here, there were 3 arms, aspirin, rivaroxaban alone, and the rivaroxaban 2.5 plus aspirin, in other words, the DPI dose. And you can see that this strategy was associated with a significant reduction in ischemic events compared to aspirin alone. And actually, pretty interesting, this is one of the few trials in the past several years which were interrupted prematurely due to overwhelming benefit. And this overwhelming benefit was represented by a reduction in mortality. There was a significant reduction in stroke, which is what you expect to see when you add an anticoagulant. in these patients, and the trend towards a reduction in myocardial infarction. An interesting finding from the trial was that patients with PAD had a reduction not only in MACE, but also in major adverse limb events. We typically do not have seen too many of these trials where we also have a reduction in these important events in patients with PAD, and these findings were further confirmed in another trial called the Voyager PAD. So definitely an important combination in patients with peripheral vascular disease. Nevertheless, just like we've seen with all the DAPT trials, even with the DPI trials, there is an increase in major bleeding. So this is not trivial. We have an increase in major bleeding. There weren't any differences in fatal and non-fatal intracranial hemorrhage, although numerically increase. But again, as we've seen in all the trials of intensified therapies, either with DAPT or with DPI, there is more bleeding. Here I have highlighted all the studies of intensified antithrombotic therapy for long-term secondary prevention in patients with chronic coronary syndrome. And again, across the board, when we looked at DAPT trials and when we look at DPI, we're overall looking at around a 1% reduction in ischemic events with a trade-off of a 1% increase in major bleeding complications. So what do the guidelines say? The European guidelines, in my opinion, do a much better job than the ACC guidelines. And they say that in patients at a high risk for ischemic events and without high bleeding risk, these should be considered a class 2A. So to answer the question, when should they not be used? By definition, if you're at high bleeding risk, you should not be using any of these strategies, DPI or DAPT. While it's a 2BA if the patient is at moderate risk. So when you think about it, 2AA is a pretty high recommendation, and this is based on all the trials that I've showed before. And the high definition of high ischemic risk, I think that is also a pretty simple definition. I typically say the rule of 5, right? You have multivessel disease, recurrent MI, diabetes, CKD, and polyvascular disease. So if you have multivessel disease plus at least one of these enrichment factors, you are by definition at high ischemic risk. And I think as interventional cardiologists, we can count to 5, so this helps. The problem with the guidelines is that they do not distinguish between which of these strategies. Is it either DAPT or DPI? Now, I'd like to be the devil's advocate here as it comes to the DPI strategy. And we know that in the COMPASS trial, the mean time from an MI was around 7 years. But we know that in real-world clinical practice, if you're going to decide to stay on intensified therapy, you make that decision at 1 year. It's not like you wait 7 years and say, hey, I'm going to start you on DPI. So, and also if a patient is doing fine on aspirin many years after MI, why would you start DPI? Let's not forget that in the COMPASS trial, most patients were on aspirin, and these were not patients that were switched from DAPT to DPI. We don't have any data on that. And we know that many patients in the future will require PCI, so why not just stay on DAPT instead of switching to DPI? I'm going to conclude with this algorithm, which we recently published. And who are the patients who should or should not be on DAPT or DPI? Well, if you're high risk for bleeding, if the answer is yes, you should not. You should just be on single antiplatelet therapy. If you are not at high risk of bleeding and you have enrichment factors, and the answer is no, again, it should be single antiplatelet therapy. If the answer is yes, and you follow one of those criteria which is just mentioned, I always ask the question, does the patient have a prior ischemic stroke? I say this because most of these patients were excluded from the prolonged DAPT trials. So if the answer is yes, then a DPI strategy would be preferred. If the patient, if the answer is no and the patient had prior MI, either one, and without a prior MI, the DPI strategy is shown to be better. Thank you very much for your attention.
Thank you, Dominick. We're going to move to the next lecture. Is I think most promising, the next antithrombotic drug, Factor Xa 11 inhibitor in the available RCT, and Dr. Roxana.
Hello. Thank you so much for having me, and I'm delighted to speak with you about factor 11 inhibitors in available randomized clinical trials. There are so many different ones that are coming forward. It is important for you to note my disclosures. Well, finding that sweet spot is exactly where we are all heading for. We want to find the best place for our patients where we can give them a regimen that will give them the lowest risk for both ischemic and bleeding events. We know that our job is to help these patients improve their outcomes. And at the moment, we're almost there, but not quite. And you wonder, how can we get there? How do we go to a place where we could actually enjoy the benefit of ischemic protection without increasing bleeding harm? So the big question to everyone is uncoupling hemostasis and thrombosis actually possible? And we understand that there is this very important differences between hemostasis and thrombosis, where you have in hemostasis a consolidated clot, where in thrombosis it's a stable clot. And of course, we have been through heparins, VKA, DOACs, all of them, looking and combining these things, and the level of inhibition is in the in a way that while you can inhibit the stable thrombus, hemostasis is not being established. So there are issues with increasing bleeding events. But factor 11 inhibitors can be the future for the promise for the future. They have the capability of going upstream to factor 11, inhibiting the stable thrombus for forming, but also importantly not affecting the hemostasis. And how is that? Because when factor 11 inhibitors are used, thrombin amplification is inhibited, prevents the pathologic thrombi, but because the tissue factor pathway still produces thrombin on the other side, allows for beneficial blood clots forming in, let's say, areas that are important for bleeding. What evidence do we have that factor 11 could be a target? Well, in human deficiencies of factor 11, there is these patients, these subjects have reduced risk of thrombosis and rarely experience spontaneous bleeding. And the genetic epidemiology studies and large cohort studies have shown us that the risk of thrombosis is twofold higher in subjects with high factor 11 levels compared with those with normal levels, and 40 to 90% lower in those with reduced factor 11 levels. The animal studies also show us that factor 11 inhibition attenuates thrombosis in mouse, rabbit, monkey, baboon models without increasing bleeding. So this all brings us some hope for the future in factor 11 as a target. The promising candidates are either the small molecules, asundexian and milvexian, or the antibodies of abelacimab, but also there are oligonucleotides that are also being developed. But the monoclonal antibodies have been studied, and they have also shown some important benefit and promise. The overview of the clinical trial investigation for factor 11 inhibition is tremendous. You can see it all listed here, where there are several studies completed, especially in that phase 1 and 2, but now in the phase 3 studies going forward. Where we are with asundexian, there was a very, very excellent Pacific phase 2 program that looked at different dosing and came up with very, very large numbers of patients in AF, in AMI, and in stroke. And as you notice, in the AF program, they only used 2 doses. In the AMI program, 3 doses versus placebo. These were 2 doses versus apixaban, only 750 patients. But you see in AMI, large numbers of patients, in stroke, much even larger. All of those were presented in these past couple of years. And we know that the phase 3 programs were well underway with Oceanic AF, with large numbers of patients, 18,000 asundexian versus apixaban, and oceanic stroke and oceanic aphena in those patients who are not eligible for oral anticoagulant. And we also have learned that this last year, due to lack of efficacy, oceanic AF was stopped early. So this other programs, the aphena is on hold, hasn't started enrolling, but the oceanic stroke continues to enroll. Moving to the small molecule milvexian, there was a lot of work done in axiomatic TKR in patients who had total knee replacements with the oral factor 11 inhibitor milvexian versus enoxaparin in undergoing these surgeries. And they had a very, very important effectiveness in the postoperative milvexian being effective for VTE prevention and associated with less clinical bleeding compared to Lovenox. Very, very interesting. The milvexian axiomatic SSP for stroke looked at multitudes of dosing with different office visits, large numbers of patients, almost 2,400 patients. There was no dose response in the primary composite endpoint, but the doses of 25 to 100 milligrams were associated with fewer symptomatic ischemic stroke, and there was some numeric increase in BARC3 bleeding with the 50 milligram dose, but no fatal bleeding was seen. And of course, the Librexia programs are well underway for both stroke, acute coronary syndromes, and atrial fibrillation. All of these using the lowest dose here at twice a day, and with about 60,000 patients underway, 50,000 patients underway. And last but not least is the antibody abelacimab, and this is a monoclonal antibody that inhibits factor 10, factor 11, and factor 11A. It's intravenous, subcutaneous, has a 1 hour, about a 1 hour half-life of 30 to 44 days, but 1 to 3 weeks if you use it subcutaneously for mechanism of action. The TKA studies were done with phase 2, and they showed fantastic, the single dose after knee arthroplasty was effective in preventing VTE with very low risk of bleeding, almost none. And of course, these two programs, Azalea TIMI 71 and Lilac TIMI 76, both in patients for moderate, in AF patients with moderate to high risk of ischemic stroke, and then those patients for in Lilac with patients with AFib who were unsuitable for the current available anticoagulation. And we saw Azalea 71 being presented at AHA this past year, showing a fantastic benefit in inhibiting factor 11A, and of course, very important low rates of bleeding compared to rivaroxaban. So a clear winner here for this. And I think what's going on here is that there are lots and lots of ongoing factor 11 inhibitors, studies going on in multitudes of populations of end-stage renal disease, cancer, AF, stroke, TIA, and ACS. And all of this is a promise of the future. And I think it really truly is, because targeting residual thrombotic risk without increasing bleeding events is almost a dream that we're all looking for. And I think that these studies really hold a great promise for the future. And I want to thank you for your attention for this.
Thank you, Roxanne. We move to the last talk. It's about Professor Byeong-Nam. It's a long-term DOAC management in the APIP and stable CAD, expectation on EPIC-CAD trial after a 5 trial.
Thank you, Professor Park. I'm really pleased to be invited to TCTAP and to talk about this long-term DOAC management in patients with stable coronary artery disease. The major contents of this presentation is an overview on antithrombotic management in AF and coronary artery disease. And this is largely a gradual reduction from triple therapy to double, and double therapy to single monotherapy. In this last part of this presentation, I'll briefly introduce our new EPIC-CAD trial and its clinical implication. The AF and coronary artery disease overlap in a significant number of patients, and the treatment, the problem in treatment is two conditions, is that for coronary artery disease or stent thrombosis, dual antiplatelet therapies do much better than oral anticoagulation. However, for patients with atrial fibrillation, oral anticoagulation is essential. For treatment of these patients, the triple therapy seems to be optimal antithrombotic management. However, the risk of bleeding is just enormous. In patients who receive triple therapy, the risk of bleeding the major bleeding is about 5 to 10% a year. And in some patients with high risk of bleeding profile, the risk rises to about 15 to 20% a year. So the risk is just incredible. So many trials try to evaluate the role of dual antiplatelet treatment compared to the conventional triple therapy. The worst was the first to evaluate the role of the warfarin-based dual antiplatelet treatment compared to the conventional triple therapy. And the results of this trial demonstrated that the dual therapy group was associated with a significant reduction in the bleeding complications compared to the triple therapy, and there was no increased risk of thrombotic event. So in the following major trials using NOAC-based dual therapy compared to the conventional warfarin-based triple therapy, all these 4 trials unanimously demonstrated that dual therapy resulted in significant reduction in the bleeding complications, and also there was no significant difference in the main hard outcomes of death, MI, stroke events. So current management guidelines of patients requiring oral anticoagulation and undergoing PCI is to very short duration of triple therapy, which is followed by dual antithrombotic management. And all this guideline is supported by these multiple randomized controlled trials. How about this long-term management with stable coronary artery disease? The current guideline suggests single oral anticoagulation alone. However, this recommendation is not supported by sufficient scientific evidence. So we started this EPIC-CAD trial, which is a Korean multi-center randomized trial that compares the edoxaban monotherapy versus dual combination therapy of edoxaban plus single antiplatelet treatment. However, while we are comparing for this trial, 2 important trials were reported. The first one was OAC alone, which is from Japan and published in 2018 in Circulation. This trial compared the OAC oral anticoagulation alone versus combination of warfarin-based oral anticoagulation plus single antiplatelet. Unfortunately, this trial was terminated prematurely because of the very slow recruitment of patients. It was mainly because the reluctance to stop omission of aspirin among the interventional cardiologists. So the result is just inconclusive. The second trial was AFIRE, which is also from Japan and published in 2019 in New England Journal. The format is about almost the same, almost identical settings, and this trial compared the rivaroxaban-based monotherapy versus rivaroxaban plus single antiplatelet treatment. they nicely demonstrated that the single monotherapy was not inferior to the combination therapy. At the same time, the same single therapy reduced breathing complication by about 40%, a significant reduction in the breathing complication. So after these two trials, the current guideline for the stable coronary artery disease is single monotherapy of oral anticoagulation. However, these trials have important limitations. The first one, OAC alone, used mostly warfarin, and it was prematurely terminated due to the slow inclusion. The second OFIRE trial was used rivaroxaban, but they used only low-dose regimen, which is approved only in Japan. So our EPIC-CAD trial will be the first to use a standard dose DOAC regimen. And the patient recruitment was completed, and 1 year follow-up was finished last September. So in conclusion of my presentation, AF, after acute coronary syndrome or PCI, early discontinuation of aspirin and change from triple to double is indicated. In chronic coronary artery disease patient, oral anticoagulation monotherapy is indicated. However, the scientific background is still not strong. So our EPIC-CAD trial will be the first to use standard dose DOAC treatment for this indication, and the results will provide solid scientific background for this patient with AF and stable coronary artery disease. Thank you for your attention.
Thank you, Professor Nam. We have a 10-minute discussion time. And any comment?
Yes, I have a question for Professor Nam. In the EPIC-CAD, you said the endpoint was designed for superiority of the NOAC alone versus the NOAC plus SAP, correct?
Yes, it's a combined safety and efficacy endpoint.
Thank you.
I have also a question. My understanding from the Master DPT trial was that patients on the OAC are really at high risk for bleeding. And in our Master DPT trial, we also showed, because it was pre-specified, that the OAC population in those high bleeding risk patients, the shortening of the dual therapy, meaning NOAC with clopidogrel in most cases, was better to stop at 6 months than to continue up to 12 months. And here you are doing a study where you want to do in this high bleeding risk patient population, really they are really high risk, to even prolong dual therapy. So for me, I think we should go back. We should not go prolong dual therapy. We should maybe shorten dual antiplatelet therapy.
Yes, the current recommendation for DAPT is shortened to 6 months, and we also adapted this strategy, and we included patients after 6 months in stable coronary artery disease, and if the patient has ACS or myocardial infarction, included patients after 12 months of dual therapy.
Yeah, EPIC-CAD trial is mainly targeting stable CAD. In the ACS population, it's beyond 1 year enrolled, and the stable angina and if the PCI stenting is we enrolled after 6 months, and after the requirement period, beyond the requirement period, the dual antiplatelet therapy, and then the randomization.
I feel like, it's just very interesting to sit here and look at all these studies, and I think the issue of what to do at beyond a year or so is so fascinating, and but mostly you just come back and think, like, how did we get, or why are we so persistently addicted to aspirin, right? Isn't that the problem? Is aspirin just it was good for a very long period of time, and now we have so many better regimens that don't involve aspirin for, long term. And again, here, I just feel like we have this, we're just hanging on for dear life to this drug that we've been using forever and ever and ever in face of, persistent mounting evidence that aspirin probably doesn't help any patient who's getting, beyond maybe the first month, just doesn't help any patient who has some other, antiplatelet or anticoagulant therapy on board. And and the guidelines, people aren't helping, as we discussed earlier. But I'd like to hear from some of the people who are deep in clinical practice and things like that, like Sripal or something like can't we just get rid of aspirin? Can't we just do we need psychotherapy to ditch our addiction? What's the issue here?
I completely agree with you. In my practice, I tend to drop aspirin 1 to 3 months, whatever the time frame is. But also being part of the guideline committee, we see the challenges, right? There's so many trials, so many combinations, so it's very difficult to actually parse them out and say, this is what you need to do.
You just have to, look at the big picture. The only thing I worry about, honestly, at this stage about getting rid of aspirin is what happens when the person inadvertently or advertently, comes off the one antiplatelet drug they're taking or the one, oral anticoagulant. What do you do around the time when they need some major non-cardiac surgery? I feel like that is, frankly, the only thing that worries me, very much about getting rid of aspirin in the long term.
And that's where, and you raise good points. There's the other issue is, in countries like in the United States where aspirin is over the counter, you may be telling the patient to take P2Y12 inhibitor monotherapy, but in reality they're actually taking DAP because they're just popping an aspirin. But the surgical question is a really a big question. We get every day how many requests for pre-op clearance and what do you don't do, and when the patient's on aspirin, it's easy, right? Or if the patient's on DAP, you drop the P2Y12 inhibitor, it's easy because the surgeon or the dentist, the gastroenterologist, they will not do a procedure on a P2Y12 inhibitor monotherapy. And so we need studies there.
Yeah. Do we have? Is there any evidence from some of them? There must be some data somewhere deep buried in Twilight and some other studies like that about what happened, because this, we published a long time ago. What's the, sort of warranty after how long can you predict that people won't need major cardiac surgery after a PCI? And the answer is 3 months. Like after 3 months, they turn into normal people and who have non-cardiac surgery at a certain rate. So there's got to be data out there that has not been published, as far as I'm aware.
I'm unaware. I know of some plans to design studies to send patients to, for example, just a colonoscopy on a P2Y12 inhibitor.
We need that data for sure.
Okay, that's your question.
Right. So from our TICO trial is also there is some very big issues in the patient requiring surgeries in the ticagrelor monotherapy. What happened, and so what's the standard protocol or something? But there was no data, right? So usually it's after changing is aspirin is more prominent. So I have a question to the Dr. Dominick. So when you look at the data of the COMPASS trial, anyway, DPI strategy would be one of the escalating strategy in CAD. So, but the data, the reduction of the stroke risk is very prominent by using the DPI. So your last slide, it is very good summarized form. So, but the problem is the high risk stroke patient having the coronary disease. It means in our Korea insurance coverage for the DPI is carotid disease is included, but they had no prominent stroke or TIA. So what do you think? This kind of shady having the high risk TIA patient is also good candidate for the DPI strategy?
Definitely yes. Definitely yes. Because this clearly, it's an anticoagulant, right? And so it is going to affect cerebrovascular events. Personally, I don't think we're not using this drug as much as one would think, because we have a great trial. But at least in the United States, the uptake has been limited, with the exception of PAD. Okay, but I believe in Asian populations where the prevalence of cerebral vascular events is very, very high. Perhaps there's more room.
Just a short
Yeah,
comment.
I'm sorry, short question to Dominick. That I think the DPI therapy very important for high risk thrombotic patient, but such kind of the patient have a high bleeding risk. So that I think the aspirin induced gastrointestinal bleeding, cerebral vascular bleeding. How do you think that low dose DOAC plus low dose P2Y12 inhibit that combination? How do you think that?
I think it's a better combination.
I see.
But unfortunately, the makers of the drug did not proceed with their phase 3 testing. They did phase 2 testing. We did our own pharmacodynamic testing, and we believe that the combination with the P2Y12 inhibitor is better.
In Japan, we have a 2.5 milligram plus grel. Now, my daily practice combination.
So my short question to the panelists would be short answer. And and the milvexian trial is a live-rexia ACS, live-rexia APIP, live-rexia stroke. 15,000. I think a pharmaceutical company in the aspect is just two exit. One will be a big success or one of bankruptcy. How is it, without any confidence, we can do 3 consecutive trials.
I have hopes for the AFib trial with milvexian. I'm not so confident about the other scenarios.
No confidence.
Not so confident.
Okay, thank you. And this is a very, the interactive discussion. We're gonna end up this session. Thank you.
You joined the meeting?
Okay, thank you.